Hello friends, thank you for joining me today. For those of you new to the channel, my name is Dr. Todd Fergus. I'm an interventional cardiologist based in Green Bay, Wisconsin. Today's episode is the second in a four-part series on coronary artery disease. Part 1 on the calcium score was posted earlier, and I would encourage you to browse for that. Today we'll be talking about the workup and treatment of coronary artery disease. So let's get started. Now, first of all, just as a recap, let's talk about what the coronary arteries are. These are the arteries that are the first branch off the aorta, and they lie on the surface of the heart to supply blood flow to the heart muscle, so the heart muscle has the blood flow and the oxygen it needs in order to squeeze 50 or 60 or 70 times per minute. Now, when cholesterol plaque builds up in those arteries, that's what we call coronary artery disease. But let's first talk about the difference between obstructive versus non-obstructive coronary disease. So in non-obstructive coronary disease, there's just some mild plaque buildup. And while that may not cause any symptoms, it is a marker for increased risk of future cardiovascular events, and so it needs to be treated, usually with a combination of lifestyle modification and medications. Now, when we're talking about obstructive coronary disease, that means that there's actual blockages, and that blockage in the artery can obstruct blood flow and limit the amount of blood that can get to the heart muscle territory that is supplied by that particular coronary artery. And again, obstructive coronary disease needs to be treated with lifestyle modification, medications, and oftentimes more than just that. So patients don't generally come into the office and say, "Doc, I have a blocked artery, what can I do?" They usually present with a variety of any number of symptoms. So those symptoms that come from blocked arteries are called angina. Angina can present in different ways. Sometimes it's chest pain, and that chest pain can have different characteristics. It's not always a sharp, hard pain. Oftentimes it's a pressure or a burning or a tightness. Other symptoms include neck pain, jaw pain, arm pain. Sometimes there's no pain at all. Sometimes it's just difficulty breathing or fatigue. And other symptoms might be lightheadedness or passing out, or it could be any combination of the above symptoms. Now, as you can imagine, there are a lot of different things that can cause chest pain and shortness of breath and fatigue. So when patients tell us about these symptoms, we need to try to tease out whether these symptoms are truly coming from their heart or not. We use a variety of different things to help us determine that. One is the characteristics of their symptoms. If they give a classic textbook description of their symptoms, such as a chest pressure that comes on every time they walk up a hill and it radiates into their arm and their jaw, well, that's a lot more likely to be from their heart than someone who says that their chest pain comes on after eating a bratwurst and drinking a six-pack of Schlitz. We also look at their risk profile. So someone who comes into the office with some symptoms and they're 79 years old and have had diabetes for the last 50 years, they are much more likely to have a cardiac etiology of their symptoms versus the 25-year-old who is totally healthy. We also use the EKG to help gauge their level of likelihood of having heart disease. We also look at any previous testing that they've had. Some patients come in having had a calcium score done before. If their calcium score is 0, then there's a lower likelihood that their symptoms are coming from their heart than someone who has had, say, a calcium score of 1,000 in the past. So once we've obtained all this information, we try to categorize that patient as either being low risk, medium risk, or high risk. A low risk or a low likelihood patient, so let's take that 25-year-old person who's only having chest pain after they eat a kielbasa. Well, for them, we'll probably just provide reassurance and look for other etiologies of their symptoms. As opposed to someone who's a high risk or high likelihood patient to have obstructive coronary disease, that's the patient where we can already just initiate treatment. We'll tell them to start taking an aspirin, maybe start treating their cholesterol, and probably initiate some additional workup. Now, the problem comes in the intermediate risk patients. So these are patients where they maybe have some risk factors for coronary disease, but their symptoms aren't terribly typical, or they're giving a pretty classic history for angina, but they're an otherwise healthy person who appears on the surface to be low risk for having heart disease, these are the patients that usually will require some additional testing to try to determine whether their symptoms are truly coming from their heart or not. The most common additional testing that we order is a stress test. And stress tests come in a variety of different flavors. When we're ordering a stress test, we first have to decide what type of stressor we're going to employ. So the most common one and the one that most people think of is a treadmill stress test. We have a standard protocol where someone walks on a treadmill at a specific speed and incline, and we have the patient hooked up to an EKG to monitor that patient while they're walking on a treadmill. There are some patients who, for either physical or a variety of medical reasons, cannot walk on a treadmill or should not walk on a treadmill, in which case we do what's called a pharmacologic stress test, where we give a medication to replace the work that the treadmill would generally be doing. Once we've decided on the type of stressor that we're going to use, then we need to decide on what type of imaging we're going to use. So usually, in addition to having someone walk on a treadmill, we also do some sort of imaging, and we might do an echocardiogram type stress test where we do an ultrasound of the heart immediately after the patient has done their stressor, or we might do a nuclear, or in some patients, we actually do no imaging. Sometimes just the treadmill EKG is sufficient. This is a picture of a nuclear stress test where we have a row of images that we've obtained at rest, and then a row of images that we've obtained with stress. We should have a nice bright orange all the way around. And in this case, we have bright orange on the resting scan, and then a clear, darker area or a defect on the stress scan. That's what's called a reversible defect, and that would generally imply that there's a blockage in the coronary artery that supplies that territory. There are other tests that we can do when we're evaluating someone for coronary artery disease, things like CT angiograms or PET scans or MRIs. These are generally less common than a standard echo or nuclear stress test, but they all have their role and they all have their pros and their cons. Once we've received the results of those tests, we have to go back and revisit the risk stratification. So remember, the patients that we're getting additional testing on are the intermediate risk patients. So if that intermediate risk patient had a normal stress test result, that moves them from intermediate risk down to low risk, at which time we can reassure the patient that their symptoms are probably not cardiac, and we can consider other etiologies of their chest discomfort or other symptoms. If that intermediate risk has an abnormal stress test or any other abnormal test result, now they've moved up into a higher risk category, at which time further evaluation and treatment is probably warranted. Now what? Now we've decided that this patient probably has obstructive coronary disease, and we need to decide what to do. Remember, the primary treatment is lifestyle modification and medications to prevent cardiovascular events like stroke, heart attack, and death. However, in this patient with obstructive coronary disease who came in with symptoms, we also need to treat their symptoms. And we can do that with anti-anginal medications, and there's 4 different types of anti-anginal medications. There's beta blockers, calcium channel blockers, nitrates, and ranolazine. In this patient with presumed obstructive coronary disease, we may also want to determine the extent of their disease with some additional testing and potentially even go in and fix some blockages. And in order to investigate their coronaries further, that would require the next step, the next test, which is called a coronary angiogram, also called a heart catheterization. Now, a heart catheterization is where we take a catheter, which is nothing more than a small hollow tube about 2 millimeters in diameter, and we insert that tube through an artery in the heart, either through usually the wrist or through the femoral artery in the groin, and we thread that catheter up to the heart and inject X-ray dye directly into those coronary arteries. When we inject the dye into the coronary arteries, we get a picture like this, where we can see the 2 left-sided coronary arteries called the LAD and the circumflex, as well as the right-sided coronary artery called the RCA, or the right coronary artery. And in this picture, these are nice, smooth, open tubes that we could say have no blockages in them. Alternatively, we might see something like this, where we see a severe narrowing or a severe blockage in that artery. And once we've found that blockage, we need to decide the best way to manage that blockage. And you can do that either with a balloon and a stent, what we call angioplasty, or it could be fixed with bypass surgery, or sometimes these blockages are best left alone and just treated with medications. That can be a complex decision as to the best way to treat a coronary blockage, and that will be the topic of a future episode. But remember, regardless of what we're doing with that blockage, we still have to do the basic things to prevent cardiovascular events, because the primary goal of treating coronary disease is preventing stroke, heart attack, and death. And we can do that through a combination of lifestyle modification, which includes diet, exercise, and smoking cessation, as well as medical therapy, including treating diabetes and high blood pressure with medications, and oftentimes aspirin and a cholesterol medicine. That's all I have for today. Please stay tuned for parts 3 and 4 in this series. I hope you enjoyed today's episode, and if you did, please hit the like button and also subscribe to be notified of future content. And in the meantime, stay active, eat healthy, and be well.